Assalamu alaikum. Today we will talk about lung mechanics. We will discuss pressure, volume, and flow, which will affect the compliance, resistance, time constants, which are the determinants of equation of motion. In spontaneous breathing patients, the gas flow from the atmosphere to the alveoli by difference in pressure from the atmospheric pressure and the alveoli. Atmospheric pressure, which is positive, alveolar pressure, which is less positive than the atmospheric pressure. This will allow gas to flow. And the reverse will occur during expiration. The high pressure in the alveoli will allow gas to flow to the outside. So, in the positive pressure ventilation, the high pressure gas source will allow the flow of gas uh, through the open the inspiratory valve into the respiratory system till inflation of the alveoli. And while during expiration, the expiratory valve will open and the alveoli will deflate. So the force required to push air into the lung is the pressure, while the speed of air that fills the lung is the flow, and the amount of air that fills the lung is the volume. In pressure control ventilation, we adjust the pressure, and in volume control ventilation, we adjust either the volume or the flow. Six important pressures we should know by heart are the peak pressure, plateau pressure, transpulmonary pressure, positive and expiratory pressure, driving pressure, and mean pressure. The peak pressure, which is the pressure required to overcome the airway resistance, which is started from the inspiratory valve till the end of the respiratory bronchioles. So it's a pressure at the proximal airway. The maximal pressure at the proximal airway. And plateau pressure, it's the alveolar pressure, which is the equal to the pressure inside the alveoli while there is no flow. How we can measure this pressure? By using the inspiratory holds for holding the inspiratory hold for 3 to 4 seconds. At this time, there is no flow in the alveoli. So the pressure measured at this time, it's the alveolar pressure. It's only measured in patient ventilated with volume control ventilation. So the peak pressure is the maximal pressure as a proximal airway, and the plateau pressure is a pressure inside the alveoli. Which is important, peak or plateau? The, the plateau pressure less than 30 centimeter water in patient with low tidal volume, less than around 4 to 6 ml per kg or double the dead space of the patient, is associated with better survival than the higher the group with higher tidal volume around 12 ml per kg. So we have to keep eye on the plateau pressure while we are ventilating our patients. Also, we have to know that there's um, high peak pressure to manage the reason of high peak pressure and to exclude there's any airway obstruction during managing the mechanically ventilated patients. What about the intrathoracic pressure? The most important intrathoracic pressure are the intrapleural pressure, which is the pressure within the pleural space, and the alveolar pressure, which is the pressure inside the alveoli. So during spontaneous breathing, the intrapulmonary or the alveolar pressure is -1 or -1 or +1. We should know that it's minus to the atmospheric pressure and +1 to atmospheric pressure, which is 0. Okay. So the intrapulmonary pressure is negative during inspiration, positive during expiration. While the intrapleural pressure is more negative than intrapulmonary pressure, it is 10 during inspiration, during deep inspiration, and it's -5, around -5 during expiration. While in positive pressure ventilation, during inspiration, pressure, all pressure will be above zero, above the atmospheric pressure at the mouth or the upper airway. While in exhalation, the atmospheric pressure at the at the mouth is zero, while the pressure inside the alveoli inside the alveoli is positive, and the pressure, the intrapleural pressure is less positive or slightly negative. Okay, the most important pressure gradients during ventilation or during inspiration is the transpulmonary pressure. The transpulmonary pressure, it is the pressure difference between the alveolar pressure and the pleural pressure, which allow alveolar inflation. While the trans-airway pressure is the pressure between the mouth or the airway and the alveolar pressure, which is the pressure responsible for the air conduction. And the transthoracic pressure is the difference between the alveolar pressure and the atmospheric, the pressure outside the body, which might be negative as in negative pressure ventilation or positive in patient with managed with hyperbaric oxygen. The transpulmonary pressure, as we said, is the standing pressure of the alveoli, and it's measured by the esophageal tester. If the pleural pressure is zero, as in patient with pneumothorax, so the transpulmonary pressure will equal the plateau pressure and the alveoli will collapse. So transpulmonary pressure is a very important pressure for alveolar distension. For example, if the plateau pressure is 20, and the pleural pressure is plus 5. So the transpulmonary pressure is 15. The and another example, if the transpulmonary pressure, the pleural pressure it is 20 and the transpulmonary pressure is 15, so the difference will be 5. There is there is a problem in distension of the alveoli because there is very low transpulmonary pressure. The accepted transpulmonary pressure better not to exceed 25, but better not to less than 15. Okay, from 15 to 25. For example, if the patient is normal patient, non-obese patients, transpulmonary pressure is 17, and there is good distending pressure for the alveoli. Why? In obese patients, if the plateau pressure is 31 and the pleural pressure is highly positive, is 20 if there is pleural effusion or compression from outside by mass or by um, obese patients. So the distending pressure was only 11. So the alveoli will never distend. So in obese patients, or patient with abdominal distension, plateau pressure may be needed to be higher than 30 centimeter water. But if we allow the plateau pressure to be higher than 30 centimeter water, we should apply esophageal tester. Never to allow plateau pressure to be higher than 30 centimeter water while you are not measuring the pleural pressure. So the transpulmonary pressure in patients with negative pleural pressure, if the pleural pressure is minus 5 during expiration, the difference will be 25. While if this pleural pressure is highly negative, as we will said now, there is a difference will be 40. So there is high pressure gradient which allow over distension and hyperinflation of the alveoli. This occur in patients with excessive inspiratory efforts. So we should not leave our patients tachypneic uh, for uh, for a while. This will lead to high transpulmonary pressure and will lead to what is called SILI, self-induced lung injury. So the patient with active expiratory effort transpulmonary pressure may exceed plateau pressure. So what about the positive end expiratory pressure? The positive end expiratory pressure it's achieved by controlling the expiratory valve by which will lead to positive positive pressure in the lung at the end of expiration. The driving pressure, it is the difference between the plateau pressure and the positive end expiratory pressure. Why driving pressure is important? A lot of study was discussing this important difference between the plateau pressure and a positive end expiratory pressure. And it was found that if we are setting a beep of around 5 centimeter water and the plateau pressure is steadily rising. So there is high risk of mortality. There is a big difference between the PEEP and plateau. So this lung is non-recruitable lung. Also, if we increase the PEEP and there is correlation between the increasing PEEP and increasing plateau pressure, also it will lead to increase mortality. While in patient we are increasing PEEP, but the plateau pressure is not increasing more than 30, so there is a very good prognosis for recruitments and outcome for those patients. So driving pressure better not be more than 15, and in some trials it's accepted to keep it not less than 18. It's okay for less than not 18, not less than 18. Was associated with a poor survival. So it's important to keep eye on the driving pressure for all your patients. So keep eye on the plateau pressure, keep eye on the driving pressure. We will, as we said, we measure the plateau pressure in volume controlled patients by using the inspiratory hold for the 3 to 4 seconds. The mean airway pressure, which is automatically measured in the most of the ventilators, the mean airway pressure is the area under the curve of the pressure curve. So there's we increase the inspiratory time, the increase the tidal volume, the increasing the PEEP, all will lead to improving oxygenation. What we are doing in this, what we are doing in patient with ARDS. Also, all right, what about the correlation between flow, pressure, and resistance? The resistance of airway will oppose the movement of gas, and this will create pressure. So resistance will create pressure. And the resistance, it is the correlation between peak pressure and flow. Normally, the resistance is less than 10 centimeter water per liter per second. Also, in with is increased pressure will increase resistance and the patient with bronchospasm or increased bronchoconstriction. If there is the difference between the increased resistance, we will find the difference between the peak pressure and plateau pressure. Plateau pressure is not increasing, but only the peak pressure is increasing. So the main problem is in the airway, proximal airway nodes in the alveoli or lung parenchyma. The sensibility of the lung, the compliance, will oppose volume change, and this will also create pressure. So the amount of air that fills the lung will also create pressure inside the lung. So compliance is a correlation between volume and plateau pressure, but we have two different compliance: dynamic compliance and static compliance. What's the difference between this? The static compliance is a correlation between volume divided by plateau minus PEEP, while in dynamic compliance, it is the volume divided by peak pressure minus PEEP. Always the static compliance is higher than the dynamic compliance. Normally, the plateau pressure correlated with the volume and compliance. The plateau pressure, as we said before, it is the intra-alveolar pressure after occlusion of the airway during inspiration by using the inspiratory hold. The increased plateau pressure will occur in ARDS, lung fibrosis, alveolar edema, or will lead to decreased compliance and increasing plateau pressure, while in equation of motion, so it includes both pressure. Pressure used to overcome the airway resistance, which is a pressure used to overcome the airway resistance, plus pressure to overcome the lung compliance, to overcome the elastic recoil of the lung. Total pressure would include the resistance multiplied by flow plus volume over a compliance to open the alveoli. So we have two pressures should be followed during mechanically ventilated patients. The first is the resistance, and the second is the pressure, which would open the lung, the pressure to overcome the lung compliance. What is the time constant? It's the time that it will take to inflate or deflate the lung. Time constants, one time constant is the one time that inflate or deflate the lung by 63%, while two-time constant will inflate or deflate the lung by 87%, and three-time constant will inflate the lung by 95%. So what's the importance and what's the determinant of time constant? The normal time constant is 0.5 to 0.7 seconds, and we have two factors that will affect the time constant. Time required, as we said in the equation of motion, time required to move the gas through the airways, which is the airway resistance, time constant will increase. Time required to inflate the lung, which will affected by the lung compliance. So the time constant is the airway resistance multiplied by lung compliance. So in COPD patients, where there is high resistance, time constants will be increased. While in ARDS patients, there's lung compliance, very low lung compliance, and the time constant will be decreased. So the time constants, it's expressed in seconds. It reflects the disease state in the respiratory system. The importance of time constants in those patients is to detect the expiratory time. In normal compliance and resistance, if the resistance is around 10 to 20, or the compliance is 65, so the expiratory time constant is 0.68. While in low compliance patients, there will be low time constants, while in expiratory time constants. In COPD patients, there is high expiratory time constants. Why expiratory time constant is important? Expiratory time should be at least 3 times the expiratory time constant, as short expiratory time may lead to air trapping and autopsy. How to measure the autopsy? At the end of expiration, we make expiratory hold for 3 to 5 seconds. If there is no autopeep, so the pressure will measure 0, while if there is autopeep, the pressure will be inside is positive. So we have to compensate with this autopeep by increasing the expiratory time. So the expiratory time will cause autopeep, will lead to hyperinflation. It will decrease the tidal volume, and it will increase the airway pressure. So from the expiratory time constant, we can apply the right expiratory time for all patients. In normal patients, it's around 2 seconds. In ARDS patients, might be 0.9 or 1 second. In expiratory time in COPD patients, it might be 3 or 4 seconds. Also, from the expiratory time, we can measure the respiratory rates. How? We will measure, divide the 60 seconds over the inspiratory plus the expiratory time, so we will have the normal or the accepted respiratory time for this patient. In this patient with normal expiratory time, and the inspiratory time, if it's 1, so the total cycle will be 3 seconds. 60 over 3. So the respiratory rate accepted for the patient is 20. Okay. To sum up, the pressure, flow, volume, and are three related but not the same parameters. Pressure is a force required to push the gas into the lung. Six types of pressure should be known by heart that will generated during gas motion, which include peak, plateau, transpulmonary, feed, driving pressure, and mean airway pressure. Equation of motion describes the total pressure that is required to overcome airway resistance, and lung compliance. Time constant is the time required for lung to inflate or deflate, and expiratory time should be at least 3 time constant. Thank you.